This is Brent of the Brookbush Institute, and in this video we're bringing you another manual technique. Now if you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed manual therapist following the laws regarding scope of practice in your state or region. That means athletic trainers, chiropractors, physical therapists, osteopaths, licensed massage therapists. You are likely in the clear to do these techniques. Personal trainers, this probably does not fall within your scope of practice, although you might be able to use the palpation portion of this video to aid in learning your functional anatomy in an educational setting supervised by a licensed manual therapist. Now, before we place our hands on a patient or client, it is important that we assess and have a good rationale for doing so. And of course, if we're going to assess, then we should be reassessing to ensure that the manual technique we're using is effective and we have a good rationale for continuing to use that technique. In this video, we're going to do static manual release of the sternocleidomastoid. I'm going to have my friend Melissa come out. She's going to help me demonstrate. We're going to use the same four-step process we've been using for all of our manual release techniques. We're going to talk about how to differentiate this structure from the other structures around it. And it's actually fairly simple. I think this is a structure that most of you would be very visually familiar with. If I just take Melissa's head and turn it away, you can see this line right here is her sternocleidomastoid. There's actually two heads, which if I follow just behind this head, I can feel the other one going into the clavicle. This head that you can see goes right into the sternocostal joint, right? So second step is, do we have any structures around the sternocleidomastoid that could be offended, insulted, or injured by compression? And the answer to that one is yeah, we definitely do in this case. So a lot of people are really scared of this technique, and it's because of things like the carotid artery is right behind the sternocleidomastoid. There's a lot of nerves obviously in the neck, and since we're on the front of the neck, we have things like your trachea that people don't really like getting pressed on. So we're probably not going to use anterior to posterior pressure to release the sternocleidomastoid, but there is an answer. There is a different way to release this. So let's skip to step number 3. Where are the common trigger points? Well, it ends up the common trigger points are kind of throughout the sternocleidomastoid, ranging all the way from the mastoid process up here, right? So I can go just inferior to the mastoid process and I can start feeling some increase in tissue density all the way down. And depending on who you're working with and what dysfunction they have and what history they have, you'll find varied trigger points throughout. So it's going to be important to kind of search the entire muscle rather than finding a trigger point, landing on the first trigger point or increased tissue density nodule that you feel and calling it a day. Like, you need to make sure you search the whole thing. And then of course step number 4 is, how do I get myself and my patient comfortable so that I can hold the technique long enough and my patient can relax? Since we're talking about the sternocleidomastoid here, guys, you can probably guess that sitting up is not a great idea. The only way I'm going to get the sternocleidomastoid to relax is with her head supported, and I haven't even had that much luck with that forehead headlock position that we've done in other techniques. I've tried because I have somebody in sitting and I'm trying to do a bunch of techniques all in a row. It just never really seems to work out. My suggestion is going to be to put them in supine. So go ahead and lay down. Right, the table up here a little bit. Now once she lays down, her sternocleidomastoid is going to relax, which is a good thing. Now we just have to solve the problem of, I can't put an anterior to posterior force on this muscle, right? That would look a little something like this. That's probably going to get me fired. I don't know about you guys, but I'd like to keep doing what I'm doing, so let's not use anterior to posterior force. Now, Travell and Simmons describes a very simple way around this, which is a pincer grip. Now, a pincer grip is just taking your second finger here, your index finger, and curling it like this, and then having your thumb and kind of pinching it in between. And if you have the other hand to kind of put behind the occiput and you kind of mess with contralateral rotation here and put her in a little flexion, her sternocleidomastoid becomes really lax. I can start up at the mastoid process where I might be able to use a little bit more of like a lateral to medial pressure with my fingertips, but then as I can get a hold of the whole muscle, I'm just going to put the muscle inside of that pincer grip, and I'm going to kind of search the tissue by strumming. I'm kind of strumming this way, so I need to go from, like, since this muscle is long this way, I would strum the muscle medial to lateral, right? And I'm just kind of taking segments down at a time in my little pincer grip, these little short strokes, looking for anything that seems to have an increase in tissue density or something that feels like a nodule. Now notice, guys, I'm not pushing down far into her neck. I started by palpating the muscle up here, really finding it, really knowing what I'm going for, which I just fell off inferior and slightly anterior to the mastoid process here, and then I went into my pincer grip this way. And I know some of you guys are thinking, oh man, he's gonna kill her. He's just gonna pinch off her carotid artery and game over. Well, it's not that easy to have somebody pass out like that. She would probably have some symptoms first, like nystagmus or lightheadedness, or her speech would start to slur or something weird. And more than that, as long as I'm not going in like and pinching down like real hard, real fast, if I'm being gentle with these tissues and I'm just slowly increasing my pressure, I'll feel a pulse from her carotid artery before I cut off circulation. If it pulses, I have the chance to move. And chances are, if you do this technique and you're working on this technique, you will feel a pulse at some point in time and you will have to move over a little bit. And that's okay. No damage done. I can actually feel her pulse against my thumb on this side, like right at the tip of my finger, which means I'm not actually squeezing her carotid artery. I'm actually squeezing her SCM more at like my second knuckle and my IP of my thumb. So I know where her carotid artery is. I found my densest fascicles here. I'm finding a little bit of a nodule of increased density right here, about a centimeter, 2 centimeters below her mastoid process there, and I'm just going to hold it until it releases. That's it. How bad is this?
Not at all.
Not bad at all. It's a little less comfortable if somebody has a trigger point down here. Be warned. But, like I said, if you start up here at the mastoid process, you fall off, you get a good idea of where that muscle is, and you slowly take out little parts, or not take out, but slowly strum little sections of that muscle with your thumb, and be careful when you feel a pulse. I think you guys will find that this technique is not that uncomfortable. If you want, you can even add a little stretch to the tissue by going back into contralateral flexion or back into ipsilateral rotation. This muscle, guys, is definitely very related to arthrokinematic inhibition, and you will see an increase in tonicity if somebody's sternoclavicular joint is really locked up or really hypermobile. So be aware of that as you get down here. It's always worth kind of checking on how stiff that joint is, kind of in conjunction with this technique. Stay tuned for the close-up recap. All right, so here we go with our close-up recap of the sternocleidomastoid static manual release. I'll show you guys a real easy way to find the sternocleidomastoid. If I contralaterally rotate Melissa's head here and then have her try to lift her head off the table, boom, you guys can see that sternocleidomastoid just pops right out. And then I can place my pincer grip right over the top of her sternocleidomastoid at her mastoid process, tilt her head back, and now we're in a nice relaxed position. I'll keep her in a little contralateral rotation just to keep some slack off this muscle, and then I'm just going to do my little medial to lateral strokes, right, looking for those densest fascicles. And then once I find an area of increased activity, I can move a little bit proximal, or a little superior and inferior. Keep in mind you want to be pretty close to where you think that nodule is before you start just kind of rubbing up and down the muscle, because you don't want to take a bunch of skin with you. That's going to be really uncomfortable. If I go right here and then I I just moved a little superior there, and I found a little point of hyperactivity, and I'm just going to keep my pincer grip right where it is until I feel a release. Note, I am not laying my hand on top of Melissa's neck. There's no weight from anterior to posterior on her neck that would make her feel like she's being choked or like I'm putting pressure on her trachea. I can feel the pulse of her carotid artery a little bit on just medial to my thumb. Right, so for the most part, the carotid artery is medial to the sternocleidomastoid. That doesn't mean I'm compressing the carotid artery. It doesn't mean that she's going to pass out. It doesn't mean I'm doing any damage. Like I said, I can just kind of feel the pulse, which is probably a good sign that I shouldn't press any further medially. I shouldn't press any further anterior to posterior, but I'm okay. And I can just check the rest of the muscle here. Your sternocleidomastoid does get trigger points throughout its entire length. It's a little hard to identify where the most common point would be. I do find that up near the mastoid process, some trigger points often get hidden, and they are a little easier to get to up here. You have less chance of compressing the carotid artery, and the muscle's a little easier to grab up here, so that helps. If I wanted to, I could add a little bit of tension by going back into ipsilateral rotation and contralateral flexion, just like so, if I thought that would help pin down tissues or add enough tension to maybe stimulate a stretch and autogenic inhibition. So there you have it. Knowing your functional anatomy will definitely help your manual technique. It'll help you differentiate structures so that you can place your hands where they need to be, as well as make you aware of the sensitive structures around the tissue that you're trying to target. Things like nerves and lymph nodes and arteries. Make sure that if you're going to place your hands on a patient that you have done an assessment and have a good rationale for placing your hands on that patient. And if you're going to assess, make sure you reassess to ensure that your technique was effective and you have a good rationale for using that technique again. Now with manual therapy, one-on-one live education is incredibly important. Please be looking for opportunities like workshops and mentorships and maybe even classes at your local university that can get you some one-on-one individual instruction, or at least some live classroom instruction, so that you've had a chance to be critiqued and mentored by somebody senior to you with some experience in manual therapy techniques. And before you bring this stuff back to your rehab, fitness, or performance setting, please practice on colleagues. There is no substitute for practice, and it is going to take a while to get accustomed to some of the techniques that we show in these manual technique videos. Don't expect to learn them in 2 or 3 or even 5 minutes. You want to have hours of experience under your belt working on various different body sizes and shapes, so that when you do get that first paying client, first paying customer, and you're really trying to make a good positive impact, really trying to promote better outcomes, you feel comfortable with that technique. I look forward to hearing about your outcomes and hearing your questions in the comments section of this video. I'll talk with you soon.